It's now, it's quite loud. It's now 3 o'clock. Folk are still coming in, so I'm going to just wait a couple of minutes. Jonathan, are we yet quorate? That's the first question. Quorate. Yes, thank you. Thank you. Thank you. Welcome to everybody. Can we start by taking apologies? Deborah, do we have any apologies, Liam?
Apologies listed on the attendance sheet.
On the list?
Yeah.
So apologies received by Dr. Alison Bradley, Peter Axon, Dr. Rachel Galliot, Craig Porter, Phil Pusey, Simon Fogel of Health Watch. That's it. Apologies noted, thank you. Any declarations of interest? Thank you. Any comments on accuracy for the minutes of the previous meeting? I have one remark to make about the minutes, and that's that I seem to recall we agreed last time that this was a committee that didn't do stuff, but made sure that stuff got done. So in the light of the priorities, we agreed that we would arrange for organisations that we expected to get things done on our behalf. Now, it's not incumbent upon us to behave like a scrutiny committee, but I think we ought to know who is going to do what in terms of our priorities. In terms of reducing infant mortality, there's 2 organisations mentioned in the minutes. That's the Family Strategic Partnership Group, which is a subgroup of the Health and Wellbeing Board, and the Early Years Advisory Board. And presumably that will cover that priority off. But the other 3 priorities, it's not clear who we're going to ask to be accountable for that. And rather than discuss that now, I think it's something that we should ask the officers to go away and come up with a view and bring it back next time so that we have a clear understanding of who's going to be accountable for what on our behalf. Any other comments on the minutes? In which case I'm happy to sign those off. Any questions from the public? It'd be hard to have questions from the public because we don't appear to have any, which is disappointing really, but okay, that's fine. The Joint Health and Wellbeing Board strategy, Claire McIver is going to speak to us about that. Just to say that the reason that there's a verbal report is that the consultation started 21st of January, finished 20th of February, which is only about a week ago. And it'll come to us for formal sign-off in June. Claire, over to you. Thank you.
Thank you. We're just trying to share the presentation. Just thinking about it. I can start actually while it thinks about that. So This item is specifically to recap on where we're at with the development of the new Joint Health and Wellbeing Board strategy and the consultation process that was undertaken, as Johnny's just mentioned, throughout January and February. So I intend to run through a summary of the findings of that consultation, some of the learning, the feedback and responses that we've gathered. I'll present a high-level summary. Obviously, we had a lot of opportunities within that consultation for people to provide free text responses, which become quite lengthy. So what we've done is sort of worked through those over the last week and a half to try and pick up the key themes, key learning, things that we think are particularly relevant in terms of any amendments that might need to be made to strategy and our priorities. There is some specifics which I think are probably useful either for individual organisations or partners to be aware of. So after this presentation, there we go. What we'll do is work through, that's not the right version, is it? Work through some of those specific examples and send those out to organisations for consideration and potentially further response. So the consultation ran from the 21st of January to the 20th of February. We had 227 responses. That was from 219 individuals and 8 organisations. Just before I go through the responses in any detail, just as a bit of a recap, I guess, what we were consulting on was the draft strategy with specific questions around the vision and our ambition, the priorities that we agreed as part of the draft strategy, and a sort of general overview of health and well-being in Staffordshire, how we tackle that, the key priorities for people, the key challenges and gaps that people would identify. So following some of the early feedback from the board in previous discussions, we simplified the vision and the ambition, so the vision became creating communities and environments that enable healthy choices, delivering high quality support to keep people independent and well. We will think health and well-being in all that we do. And the ambition was to reduce inequality and increase healthy life expectancy. The approach, as you're aware, was guided by the King's Fund 4 Pillars for Population Health, which aim to improve physical and mental health outcomes, promoting well-being, reducing health inequalities across the entire population. So those approaches, as you can see on the screen, are sort of shaped around those 4 pillars. So the wider determinants of health, thinking about the social factors within which we sort of live and grow up and work and age, our employment, our housing, our transport, our own individual health behaviours, choices and lifestyles, so things like what we eat, how we live our lives, whether we take exercise, those kind of things. The places and communities within which we live, so in particular thinking about our social relationships and our networks, as well as those things that influence our health behaviours and mental well-being. And also the health and care systems itself and how those services can be coordinated and tailored to meet individual needs as well as suiting organisational needs. So the 4 priorities we agreed as part of the draft strategy were again tweaked slightly as a result of early feedback and discussion with the board. So the reducing infant mortality priority, I think discussion sort of led us to thinking that perhaps needed to be more of an end goal, so an outcome as opposed to a priority area, whereas actually the priority itself needed to be a bit broader around good health in early life, and that was supported by the consultation. So the 4 priorities in the strategy are good health in early life, good mental health, healthy weight and healthy ageing. So in terms of the actual consultation itself, of those 227, I think I said 227 respondents, 61% were female, 85%-ish were white British, 2.5% white other, 1% Asian and 0.5% mixed. We had 44% aged 45 to 64 and 28% aged 65 plus. And we asked respondents about their own health issues and the impact that had on their lives, and 60% of the respondents said they had no health issues, no limiting impact. In terms of the output, so the reason this starts at question 4 is because the early questions are more the sort of demographic questions and some of the sort of processy things. So we asked about, we sort of included the vision statement and asked about views on the vision statement. really positively. 81% of respondents either agree or strongly disagree with the statement. Those who disagreed or strongly disagreed, that came to around 8.5%. Comments tended to focus on things like poor access, specifically around disability, a loss of or limited services, for example, around primary care or social care services, the need for a cohesive approach to health improvement, and also a suggestion that the vision should say that we will think health and well-being in all that we do. So you'll note from the previous slide that that's been amended in the vision statement. We asked about our priorities and asked people to rank those in order of preference and sort of importance. So you'll see here the number of respondents. Oh, gone the wrong direction. Go forward. It's okay. So in terms of the 4 priorities, the one that consistently came out as the top priority for most respondents was good mental health, followed closely by health in early life, but there was good support for all of the 4 priorities, which is really positive. We asked about other priorities, whether there were other areas that people felt needed to be included or needed to be a key focus of the strategy and the supporting actions. There was obviously lots of variation. This was another sort of free text response question, but there were some key themes that emerged, specifically around access to GPs and healthcare, physical exercise, affordable ways to keep healthy, more schemes or opportunities to promote participation in exercise for children, access to easy understand information on how to stay healthy, healthy eating, and also linking that in with climate change goals, reduction in loneliness, particularly in older age, and the environment and health as well came out a few times. There was a particular, some interesting comments around taking a whole systems approach, which I think again is really positive because that does reflect how we've written this strategy and the approach we're proposing to take. So there was talk about, there being no point in having a healthy lifestyle and a healthy weight priority if some of the decisions we make around planning or the environment don't support that and aren't conducive to a healthy lifestyle. There was also comments around making sure we're focusing on what the data tells us and that we can properly support people around those targeted and sort of increased needs, perhaps thinking about the health inequalities agenda. And there was also a sort of, I guess, a challenge or an ask of the board and partners of the Health and Wellbeing Board strategy to minimise duplication and try to ensure that teams, both within organisations and between organisations, were working closely together and not duplicating. We also asked how you as an individual or your organisation or community group could take action. These were some of the quotes from the respondents. A relatively high number of responses were focusing specifically on what public bodies should be doing rather than what they themselves should be doing. So we've sort of extracted those from the results of this question in particular. But the kind of themes that came out of this one were around helping to communicate health and wellbeing messages. So you can see here people are talking about supporting communication within the parish, about taking personal responsibility, so what more I can do individually to improve my own health and wellbeing, and also about businesses and workplaces being enablers of health and wellbeing and promoting that health and wellbeing focus. We sort of had a relatively open-ended question towards the end around what else people felt we needed to focus on, and around half of the responses either focused on access to services or how we organise ourselves as a system. So there were some interesting comments, and the type of themes that emerged were around connectivity and infrastructure, so things like transport, public transport in particular, cycle lanes, accessible and safe walking routes, housing, so thinking about how we plan housing for an ageing population and how we support and reduce homelessness, more and more accessible physical activity and leisure services, access to services such as GPs and primary care, but also hospitals and social care, schools and getting the right message to children, inequality, so how we focus on reducing poverty and focus our efforts on areas of greatest need. Digital support and recognising that access to information needs to be provided in a variety of ways, not just digital but also face-to-face. And also community and locally targeted approaches, so a real acknowledgement that a one-size-fits-all approach won't work across Staffordshire. There was also a theme around engagement with the public, so making consultation real and making that co-production real and meaningful. An interesting quote was that this board's a very small cog in a large wheel of organisations, each promoting a very similar and very valid message. As such, the board should not waste any effort or money developing or writing its own thing if it can copy and join forces with others to promote a stronger message. So I think from that we can think about how we build on the good work already happening. We've talked already about whether we can map some of the existing work streams and partnerships that are in place, bring all of those together to produce a more meaningful combined effort rather than trying to start new pieces of work where that might not be necessary, but learning where there might be gaps. And in terms of other comments, so again, there were sort of themes that emerged from this. So access to services, promoting and encouraging exercise and fitness, communication that's meaningful and targeted and understandable to the public, that organisational leadership, being advocates within our own organisations and across the wider system and the wider population, those environmental factors, thinking about the wider determinants of health. And healthy eating, again, came across consistently, so things like more access to fresh fruit and vegetables, particularly, versus areas where there might be a saturation of fast food takeaways, for example, safer streets to encourage more walking and cycling, access to a doctor on the day that I need it, working across upper tier and lower tier local authorities to make sure things like swimming and sports facilities are readily available to the whole community. Thinking about what I can do more personally to encourage friends and family to exercise and eat healthily, which I think is an interesting concept. A few comments around longer term investment, both in terms of setting our sort of medium and long term goals and that the programme delivery to get there, but also in terms of our funding and resources. References to community hubs alongside better public transport, and also more help for older people to live a healthy lifestyle, so thinking about accessibility and what facilities might be most suitable and appropriate for older people to access. So in terms of the key points then, respondents generally and broadly agreed with our vision, which I think is really positive, as did they with the 4 priorities, with mental health consistently being seen as the top priority. Some of the key themes that emerged I've just sort of summarised, I guess, but I think there was a particular focus around involving and engaging the public, so doing things with the public and that co-production and co-development, and a desire to see a better join-up of services and of organisations and that improved partnership working. As I mentioned at the beginning, I think what we'll try and do as well is pull out any of those specifics that relate to either key geographies or key services so that they can be considered by those organisations and those parts of the system. So, next steps. I think this brings us back really to the point that you made at the beginning, Johnny, around how we ensure we have ownership of each of the priority areas and that we're delivering against those. So what we'll do is, as a result of interpreting all of the feedback from the consultation, is we'll update the strategy and share the final version with the board in the next couple of weeks. That will hopefully then be our final version that we can sign off at the June meeting. The next step, I think, is for us to map all of the existing partnerships and work streams to identify those gaps, think about what work's already happening, what's going well, but where we might need to try and fill some of those gaps and how we need to bring some of that work together, and then think about how we as a board want to monitor progress against those actions to achieve our key outcomes. I think it's really important that that piece of work is done as a shared exercise across the board, so I guess there's a question about whether we perhaps set up a fixed term group to take that forward and whether we can ask for nominations from the board to do that. And I think there's also a question for the board about whether we want specific sort of senior sponsors for each of those priority themes and perhaps a project officer for each to make sure that we're sort of continuing this momentum and not losing track. I think this will also follow on and sort of lead nicely into the work we discussed around reviewing the board itself and its sort of purpose and function and its membership, particularly within the context, I guess, of the integrated health and care work. John and I have started doing some scoping to look at how other health and wellbeing boards operate, some of the good practice that's around, and what we intend to do, as mentioned at the previous meeting, is set up a workshop in the next probably couple of months before the June meeting to have those discussions in a bit more detail so that all the members of the board can reflect on how they want it to deliver against this strategy, I guess, over the next few years. And that's it from me. Happy to take questions.
First, before I open it to the floor, I don't see any surprises in there. Do you, Claire?
No, I don't. I think we probably anticipated that it would, it wasn't hugely contentious in terms of the strategy and the contents and the priorities we identified. It's not a huge shift from where the board has focused its attention in the past, and I think that's because these kind of health outcomes don't tend to change, overnight, so they are a long-term commitment. So no, I don't think there was anything that would mean we'd have to completely change the direction of the strategy or alter the priorities. I think most of the comments and responses, particularly any of the negative ones, were around specific service issues or things that were very localised to that individual.
Yep.
So I'm relatively comfortable that I think it's we've gained good support for it through this process.
Okay, thank you. Can I open it to the floor for comments? Any thoughts? Yeah.
Just a couple of reflections, Chair. So it looks from the feedback like broadly the strategy has gone down pretty well. I agree. I don't think the comments are necessarily a surprise, and seem to be issues of nuance rather than any fundamental opposition. I think that there's an interesting reflection on us about the scope as it extends to health and care services. So historically, we've tended to limit our interest in those to the Better Care Fund, and the sort of the strategic determination of service configuration has been done in other places. We tend to focus on sort of well-being. There are things in the integration white paper produced by the government that suggest that in future we may be taking more of a direct interest and have more responsibility in that area. So whilst I think this iteration of the health and wellbeing strategy we can work with, we may need a refresh relatively soon to incorporate that potential additional scope. The other one is I see from the feedback that there does seem to be more and more interest in how the determinants of health influence people's behaviour and influence health outcomes. And in the context of ever closer working between the county and the districts, I think there's a real opportunity there to harness what goes on at district and borough level and local plans and transport, and harness all of those positive influences for the benefit of health, but also linking through to the climate change agenda and improving the environment as well. Thank you.
I agree on all counts, particularly your latter point. It's always struck me as being somewhat an eccentric approach to have public health sit with, and the health and wellbeing board sit with an upper tier authority, whilst the wider determinants of health sit with the lower tier authorities. Given our current relationship with the district and boroughs, which is better than it's ever been, given the leaders board, etc., this is an ideal opportunity to really link these things together and really start to deliver something at a granular level. I agree entirely. I'm interested in Claire, your point about a sponsor and a project officer for each of the priorities. I've got some sympathy for a sponsor, certainly, as a member. I'm thinking of Anne Edgeler and her beating the drum for mental health at every opportunity. I think that's quite good. Julia.
Yes, I think that's a very valid point. In terms of the strategy, when it's finished, I think the key thing will be for this board to make sure there is, even though it only may identify half a dozen key actions and a sponsor, because it may well be that there is a district or borough authority who may want to sponsor a particular piece of work. It could be about getting their fellow planning authorities within the county to change their planning policy or their guidance, which enables them to perhaps resist more fast food outlets, or perhaps increase the amount of usable green space that there exists within new housing developments. There's all sorts of things, and I think through the Leaders Board, potentially, such an action plan can be shared with them and say, well, which one of you are going to be the sponsor for some of these key issues, picking up on your point. So I don't think one needs particularly a project manager, but I certainly would agree we need a sponsor who takes responsibility of making sure that it happens. Strategies are all well and good, but unless they lead to a change in a specific set of actions, they won't deliver anything. Just on an aside, I was rather amused that obviously healthy weight was not particularly popular amongst the respondents.
I agree. A project officer is worthwhile when things are getting done, but we're not here to get things done. We're here to make sure things are done, and therefore the sponsor is the big one for me. I think that would be helpful. I agree with that. And along with the sponsor is a lead organisation that we can hold accountable in terms of delivering for us. I think that would be particularly helpful.
So how do you want to take that point forward then, do you think, in terms of the sponsorship? Do we want to seek nominations and or volunteers?
Views, Julia.
Well, a willing volunteer is always more effective, but I just wonder whether, when the strategy is completed, if, you know, a draft action plan can be drawn up and keep it fairly simple and succinct for the first year. And then I think perhaps we ask that it be put on the Leaders Board agenda, because I suspect, I wouldn't wish to preempt at this stage, but I suspect quite a few of the actions are best taken forward at that level, and leave it up to the Leaders Board. I'm sure the Leaders Board would be more than happy to accommodate yourself as chairman, to perhaps or yourself, Claire, and yourself, to present it. But I think having a willing organisation is by far the more effective, because they know what capacity, skills they've got within their organisations to take it forward.
Are we agreed? Thank you, and thank you, Julia. Claire, thank you. So it'll be formally published in a couple of weeks and then come back for a formal agreement for us in June. Is that the game plan?
So I don't know if we would formally publish it until it had full sign-off by the board, which would, well, we could either do it virtually between now and June, or we could bring it back to the June board for formal sign-off. But we'll share it with the board in a couple of weeks, the final version. Whether we'd be able to publish it publicly before then, I don't know.
I'm keen, if everybody is in agreement, that actually we take consent via email, because that gives us more latitude in terms of what we do in June, and it means it affords us a degree of pace to get on with this. Everybody agree with that? Good, thank you. I'd like now to introduce Dr. Amit Arora, Matthew Misson, Tilly Flanagan, and John Rouse. Are you all virtual? It appears so. Yeah. Well, welcome all, and thank you. And you're here to talk us through the healthy aging and managing frailty in older age strategy. Over to you guys, and looking forward to what you have to tell us.
Thank you very much, and thank you for the invitation to be with you this afternoon. So you're going to hear from each of us during the course of the next 20 minutes or so. And we should say straight away that we're bringing this strategy both to this board and also to the equivalent board within Stoke-on-Trent, because this is a strategy that spans the whole of the integrated care system and therefore the dual geography. My day job is that I'm the city director in the city council, but as with all the senior executives across NHS and local government, we take leadership roles with respect to the integrated care system, and it's my great pleasure to play that role with respect to healthy ageing and frailty. Now, the starting point, I'm only going to speak for a couple of minutes before handing over to the main event, but one of the things that I want to address straight away up front is the issue of frailty. What is it? Because it has a common meaning, a sort of social parlance, which suggests weakness, deficit, and that isn't really what we are talking about here. Because frailty is also a clinically defined condition or set of conditions, sometimes in medical terms called a syndrome. And it's geriatric by nature, and is characterized by increased vulnerability to external stresses of various types that go with aging and can translate into very serious health conditions. It's progressive, of course, as we know, but the good news is that it can be affected. It can be affected in terms of prevention of onset in many cases, and it can be managed in terms of delaying its onset within the community. And so what we have developed and what the team have developed, working across organisations and clinically led, is a framework or a strategy that runs right from prevention through to crisis care, with the bulk of the effort around population health management to enable us to reduce the impact, both for individuals, but also overall as a system of frailty. Because here's the rub. Aside from the bad news for individuals of progressive frailty, there is a huge impact in terms of NHS and social care. It is the biggest driver of cost within our system. This has been well evidenced, not just in this country, but other countries as well. Probably the most famous study in this country was done in Somerset now over a decade ago, that showed the extraordinary impact that managing frailty has on our system in terms of cost driver, particularly when it's combined with onset of dementia as well. So really, as a system, there is nothing more important for us to focus on as a geography and as an integrated care system. And I'm going to hand over now to Amit next to start to take us through.
Thank you, John, and thank you everyone for giving us the opportunity to present here today. Can I have the slides, please? Thank you. So my name is Amit Arora. I'm a local NHS consultant and I specialize in care of older people, hence called a geriatrician, and I work across the patch between Staffordshire and Stoke-on-Trent. I also have a clinical director role with NHS England and a vice president role for the British Geriatrics Society. So the only one common thing that is happening to everyone in this world right now and together is that we are all getting older. And Staffordshire and Stoke-on-Trent is no different. And as we emerge from this COVID and as the integrated care systems develop, this quote from Atul Gawande sounds very, very relevant to what we are doing in terms of the healthier aging and frailty strategy here. And it is really vital that we blur the traditional boundaries of primary care, secondary care, community care, social care, mental health, voluntary sector, and so on. And I see it in daily clinical practice that if the system can work in a seamless way, people's journey and experience is so much better and the clinical outcomes also improve. The strategy is only the start. And as you said earlier, Chair, that the strategy has to be accompanied with actions and accountability. In developing the ICS system-wide frailty strategy, we have had a series of consultations, workshops for clinicians, patient groups, stakeholder events, including those from diverse communities. And you will also note that some of the objectives of this strategy align very well with the JSNA and the vision of this board. And that is the way it should be. It is about building on what we already have and add more to it by working together. And we would love to get your feedback, build a momentum, and we seek your support in taking this forward together. And before I hand it over to Matthew and Tilly for an update on this, I would say that the opportunity is huge and the time is now. And together, let us develop a system we all will have when we are older, because older people deserve no less. Matthew?
So thank you very much, Amit. If we could move on to the next slide, please. So during the next decade, we anticipate seeing significant growth in the population aged 65 years and above, and most notably this growth is greater in the population aged 85 years and above. What's important, I think, for us to note is that across Staffordshire, and you'll see in at the table at the bottom right of the slide, that this growth is not uniform. We see variation in this growth across the county, and that is determined by existing demographic profile within these areas, but also the health inequalities that we see in health status and subsequent life expectancy. And this in itself highlights possible health inequalities and the role that they play in healthy aging and managing frailty. Next slide. So here's a reference to Athol Gawande. Some of you may be familiar with the book, and it gives a good social narrative on some of the existing issues that the older population faces. And this is certainly, for us, it kind of emphasised some of our thinking and some of the challenge that we feel we have a real imperative to try and address through the strategy. Next slide, please. So relating to the growth in the older population that we see, we've applied a population health management approach, and our modelling alongside the increasing the older population, we anticipate seeing significant growth in a number of long-term conditions. It's important to note that these are conditions which are preventable, and their onset can be delayed, and if managed well, we can reverse or slow the progression of these conditions. But we're already seeing the demand from these long-term conditions within health and social care services. And without a significant change in our approach, we can fully anticipate the demand from these conditions to increase in future. What is also notable is that many of these conditions are also risk factors for frailty itself, if not managed well. So there's a real imperative to make sure that for those that have long-term conditions, we support them in managing their condition well. Next slide, please. But it isn't just a simple picture of increasing cases of individual diseases. What we are seeing is a changing pattern of illness, with increasing numbers of people living with 2 or more long-term conditions. This makes clinical management for these patients more of a challenge for healthcare services, but having multiple long-term conditions again poses a risk factor for frailty. So if not managed effectively, again increases individual risk of frailty. Next slide, please. So as John mentioned earlier, throughout this slide set, we are referring to frailty in terms of its clinical definition, and I think John framed that excellently. What is important to note with frailty is that it does vary in severity, and here we've almost used a way of categorizing with some estimates of the numbers that we expect to see in the population across the system. What is important to note with frailty is that it is not an inevitable part of aging until very late in life, and this is reflected in our approach. In the population that is currently healthy but increasing later life, we're endorsing a population approach which really emphasises prevention and early intervention in a kind of community setting. and looking at supporting individuals to make sure that they age well. With our population with mild frailty, we're really pushing the digital agenda and looking at what innovations there are to support self-management to reverse or slow the progression of frailty. For our cohorts with moderate and severe frailty, our focus is slightly different, and this is very much around making sure that those with more severe frailty are able to access multidisciplinary, personalised care that meets their needs and wishes in later life. Next slide, please. And there's a question of how we will do this. So we're looking at increasing the offer within communities so that those living with frailty can meet their health needs in or close to their place of residence. Frailty is itself a complex condition, and reflecting this, we endorse the use of a more systems-based approach with a number of interfaces between relevant services that enables kind of holistic multidisciplinary care. We have 4 key strands which cut across our strategy. That is addressing health inequalities that we know exist, looking at our workforce and making sure that it's reflective of need, looking at digital innovation, and looking at investment of resources to make sure that tangible action follows from our strategy. Next slide, please, Tilly. So when we take a strategic view of the strategy as a whole, there is a question of what will be different and what are we trying to do. We are looking at extending the length of life that people can expect to live in good health, and as a result of that, delay the onset of frailty. And in those that have frailty already, looking at ways in which we can support them to delay the progression or slow the progression of frailty. Health inequalities play an integral part of risk factors for frailty, and that as part of this strategy, we've also put in a number of actions that aim to reduce the difference in health status that we see between our most and least deprived communities. There's a clear public health rationale for doing so, as hopefully outlined in some of the previous slides presenting the data on the ageing population. And the strategy presents a number of evidence-based solutions to be able to address the challenge that we see. Next slide, please. So there's a number of strands, and I won't go through all of them here. Tilly will shortly present on some of the excellent work being done on healthier ageing and prevention. But if you have any questions around any of these activities that we've delivered so far, then please do ask after the slide set in the discussion. Next slide, please. So with the strategy and the implementation of it, there's a real unique opportunity for the Staffordshire and Stoke-on-Trent system to put ourselves as a national leader on how we address healthy ageing and frailty, and do it at a scale that both realises benefits for our population, but also, as John touched on, it's also looking at how we can enable self-management, enable people to meet their health needs in communities, and reduce demands on our health and social care services. An integral part of that is focusing on our prevention agenda, and we're really looking at how we can proactively use new ways of working through social prescribing, community development, and systems-based working with our existing services that support healthy ageing to really build a strong, proactive prevention agenda. With the digital revolution ongoing, we're also looking at putting the integrated care partnership right at the forefront of digital innovation, looking at what tools can be used by the population with mild frailty to best self-manage, and even looking at predictive risk tools so that we can proactively offer care to people and avoid the need for hospital admission or social care use. Next slide, please. To give an example of that locally, we have our Staying Well service. This is a really innovative new service that's been received well within the area. It's offered to people aged 55 and above, and we proactively offer it to individuals who are identified as being at possible risk of having mild to moderate frailty. The service offers personalised care from a multidisciplinary team, as well as lifestyle advice on healthy eating, exercises, and looks at addressing risk factors that we know individuals can manage themselves with follow-up from elderly care facilitators. This has been really received well by system partners, and we're looking to evaluate it to inform our future approach. Next slide, please. So with this slide, it's just to outline some of the key milestones that we have, and these are projects that we're looking at delivering with partners in spring and summer 2022. Before my colleagues Tilly starts with some excellent examples of work being undertaken by the council, I'd just like to pose two questions which John will pick up in the discussion later, and just for you to consider as we progress through the presentation. The first question is, does the healthy ageing and management of frailty strategy add value to the existing health and wellbeing strategy and priorities, particularly with reference to primary and secondary prevention and reduction of health inequalities? And secondly, how would the Health and Wellbeing Board wish to contribute and shape elements of the strategy that are more health service facing? At that, I'll hand over to my colleague, Tilly. Thank you.
Thanks, Matthew. As you've heard, there's the Healthy Ageing and Frailty Prevention Strategy has a number of strands, and one of those is around prevention. Myself and other colleagues within Stoke-on-Trent City Council Public Health team were asked to take some ownership and leadership of this work. So we've had a small working group that started to look at what does this mean for us within our areas, and that's included colleagues, say, from both councils, MPFT and the voluntary sector. It is a small group, and we know there's more that can be done, and we can certainly involve others as we develop. What was quite clear to us as we started this work is that recognising this is an ICS strategy, so we can develop a strategy across that footprint, it is really important that we look at developing bespoke plans for both those local authority areas, because some of those needs will be different and some of the solutions will be different. You can have the next slide, please. And I think this probably sort of helps explain that. So Matthew has shared a lot of the information in terms of the data, our population projections. This slide is a culmination of a lot of the insight that we actually have within the Staffordshire County Council and our service in terms of the needs that we have in terms of our own population and ageing population, some of the reasons why they actually come to us and other organisations that are asking for help. And if you can see that, there's a wide range of reasons why people come and ask for support, from help in just accessing shopping, carer support, issues around loneliness and social isolation, just finding out what is out there and available within their local community in terms of some of those activities. That's really important when we're thinking about how we can keep people healthy and active for as long as possible. But as you can see, there's a whole range of reasons why people actually come and ask for help, and this is before they may be identified in terms of mild frailty or frail or requiring services. So as a result of that, Vicky, you okay to do the next slide, please? What we've done within Staffordshire County Council, and I know Stoke-on-Trent will have done similar things, is we've actually developed and built some plans support those citizens and those people who want help and support to remain as independent and safe for as long as possible. And these are just some examples of some of the programs that are already in existence. It's not everything. We wouldn't be able to put it all on one slide, but as you can see, there are just some examples there. We have Staffordshire Connects, which is a Staffordshire County Council digital offer, but that is built on all the offers that are out there within our local communities, our other voluntary sector organisations, public sector organisations and businesses as well. And that's all linked to those reasons why people come and ask for support and help, so we can actually sort of direct people as best we can. But more importantly, that's not just for our citizens, that's also for professionals, both within adult social care, health, and other organisations. It is a tool that can be used by anybody, and we wouldn't have that tool as well as it is if it hadn't been for Support Staffordshire, who've actually helped us do the asset mapping within our local communities, and more importantly, where we identify gaps, they will sort of grow support and develop communities within those areas. And then we have other programs such as Everyone Health, which is a health improvement program to supporting people to remain as healthy as possible. And then programs such as the Staffordshire Warmer Homes, which actually is a program that involves all our district and boroughs and wider partners, and that is of how we can actually support our vulnerable and at-risk individuals, both families and communities and older population, to remain I suppose warm in their home, and that's about providing real sort of pragmatic solutions and access to information to reduce some of that fuel poverty. So there's a whole range of things there. So I suppose the important thing is that we're not starting from scratch. Next slide, please. I think what's been important, and it's been really interesting listening to Claire's presentation earlier, in terms of the health and wellbeing plan of this board already, and one of those four priorities is around the ageing well aspect. So it's quite important to sort of hear and know that the board is really interested in this area of work. It's quite interesting to hear some of the feedback that had come back from local individuals, communities and organisations. So I know there were draft priorities, but I have sort of shared those here in this presentation. And then alongside that, you can see the direct objectives that are sitting in the ICS Healthy Ageing strategy that again wants to focus on trying to keep our older population as independent and as well for as long as possible. I won't go through all of those, but as you can see side by side, if you can see them really clearly, the language may be different, but actually there are a lot of similarities. This is about how we can make sure that people have the right information, they have the right tools, and also our professionals know what they are as well, so they can support our older people to stay well for as long as possible. Can you move on to the next slide, please? So there's quite a range of priorities and objectives there, and what I've done here, I'm talking to various colleagues, it's this important bit is how you can turn some of those priorities into actions. So these here are really a list of recommendations that we would like to see develop as part of a plan. So the task that I'd been given was to develop a plan around healthy ageing, specifically for Staffordshire. That was through the ICS route, but given the conversation that we've already had or have just taken place before this agenda item, there's also a recognition about how we can actually sort of join up plans, and we can make sure we are obviously have almost one plan for actually sort of that benefits all, you know, across all agendas. So I won't run through all those recommendations one by one, but basically they are how we can turn the priorities and those objectives into actions, and I have been asked to develop that plan, a timed plan, to go back to the ICS board by September, and that might be something that we can consider in terms of the request for the Health and Wellbeing Board. So I'm going to hand you back over to John, who will as Matthew's already indicated, we've got a couple of discussion points that would be helpful to help shape the overall strategy. Thanks, John.
Thanks very much. Well, I won't detain us long so we can get on to discussion. But just to say that I hope what's come across this afternoon is that this is an immensely practical framework and strategy, the outworking of which will happen at place level for the most part. It is about sort of improving strength and balance and flexibility. It is about preventing loneliness, isolation, helping people in bereavement. It is about when they're going to hospital, getting them back on their feet as quickly as possible so they don't deteriorate too rapidly. It is about sorting out polypharmacy and make sure that the combination of medicines isn't actually inadvertently accelerating their frailty. It's about all those things and many more. And the key to this is actually about creating holistic partnership working at the place level, deep in communities, so that this becomes just a positive part of life for people as they age. So you've already heard the questions, so I'm not going to repeat them. We're here because the partnership with each health and wellbeing board is absolutely critical to our success, and we look forward to hearing your comments and views.
Thank you, John, and thank you all. I'd be grateful if we keep that slide up so we're reminded of the questions you want answered, really. But I think there's more we might wish to discuss than that. I'll open it to the floor. Anybody want to? I've got the usual suspects. I've got Richard, then Julia, and then Gary. Richard.
Thank you, Chair. So I think on the first question, I think the Healthy Ageing and Frailty Strategy and the Health and Wellbeing Strategy are complementary. I'm sure there's a lot we can do with that. On the second point, so it seems to me that effective management of elderly and frail people requires an absolutely fundamental shift in clinical practice. What we have at the moment is largely a medical approach. It regards people as patients. It focuses on treating individual conditions and organ systems, and it asks the question, what's the matter with you? What we need is a holistic approach that regards people as individuals. It focuses on maximizing quality of life, and it asks the question, what matters to you? Now, that shift is absolutely massive because it's not the way that doctors and, to an extent, nurses and other professionals, it's not the way they're taught, it's not the way they learn medicine. So I'm really interested to hear from John and probably Amit about how that's going to be achieved, what the Integrated Care Board can do to shift that practice. In terms of the Health and Wellbeing Board, I wonder whether we have a role in trying to help the public understand the limitations of that medical approach and also the benefits of that much more holistic approach and how much more compassionate and effective it is as a way to managing people in their final years. Thank you.
I think I might come in here just for a moment. I agree entirely with Richard, and Amit, I'm delighted that you mentioned Atul Gawande. I'm a bit of a fan of his, I have to say. This is a strategy, but how is the strategy going to affect the culture of the people at the front line? That's another way of asking Richard's question. Such that we don't medicalize, but we empower people in the final stages of their lives. Open to you guys.
Shall I kick off and then hand over to you, Amit, if that's okay? So I think it's a brilliant question. First of all, an absolutely critical one, because I agree, Richard, with what you've said, and I think the root of this is that the development of the clinical workforce in this country and some other developed countries as well focuses on undue specialisation. From very early, actually, in medical training, a lot of medical schools push students that actually going into a particular acute specialism is the epitome of their achievement, and that's very, very unhelpful in many respects. What we need is a rebalancing, and I think we as an integrated care system can influence that, particularly through our workforce strategy. It's about the balance of the workforce. Personally, I'm a big fan of geriatricians because I think they have a holistic view and they work up and down pathways. They can be partners both to primary care and actually work within the hospital environment in joining up specialisms as well. I think we're underprovided in terms of geriatrics in this country, and maybe that's something that we as Staffordshire and Stoke-on-Trent ICS could do something to influence in terms of the balance of our clinical workforce. Clearly, empowering primary care is very, very important in this. They also, with encouragement, have a tendency to have a more holistic view, particularly if we can carve out time for them to do that proactive management, particularly working with advanced nurse practitioners and other therapies in terms of that multi-team effort. And then finally, just bringing the social in. So, whether that's through social prescribing, whether it's about actually undertaking clinical work in social settings, whether that's within day centres or whether it's within care homes, is also, I think, crucially important in changing the culture. So there's a few things. There are probably others. So Amit, do you want to add anything?
Thank you, John. And Richard, I couldn't agree more. And thank you, Chair, for raising this very, very important and relevant question. And if you noted when I said that people are people and they only become patients for a very short period of time when they attend a doctor's surgery or the hospital, and when they go back into their homes or community, they are back to being people. I think if any of you have been onto the acute hospital wards, a lot of wards have actually started to display the questions that Richard very kindly posed, that what matters to you is more important than what is the matter with you. So I think, and I entirely agree, there is a need for a cultural shift amongst all the doctors and nurses training. And I think that is a issue we have not really particularly addressed well, although there have been startups started on this over the last 3, 4, or 5 years. And I've been kind of personally doing this very regularly in my ESIST role at a regional and national level. John also touched on the workforce, and I think some of you may have already noticed that the Royal College of Physicians have today come out with the workforce plan, calling on the government to display the workforce figures and projections and what they are doing about it on an annual basis. And I think nationally, on an average, for the age over 65, there is only about one geriatrician per 8,000 people above the age of 65, and that is very, very low. But it's not just about the geriatricians, as John says, it's about a multidisciplinary skilled workforce who actually want to do this work rather than be forced to do this kind of work. So cultural shift, absolutely. What matters to you? No. What we need to do much more on this because we haven't made enough progress on this. So entirely agree.
Can I just press this point before I move to Julia and just say, do you think that for the local ICS board to really push hard the whole bit of power of attorney is a strategic way to actually influence culture and behaviour whilst we wait for the whole medical training bit to catch up with real life?
So the power of attorney bit in relation to what, Chair?
When power of attorney is put in place, and I've got one, and I was one, it promotes frank discussions within families about dying, and about frailty and losing your marbles and all that sort of stuff. And at least that is a start of a realistic discussion about what an individual envisages the end looking like for them. Because as soon as they're approaching the end, we default to type and go to and do what we usually do, admit people all the time inappropriately, etc. But at least having that discussion with loved ones or with friends or whoever it might be, is maybe the beginnings of the change of a culture that's desperately needed. And I just wonder if that's in the sights of the ICS.
Thank you, Chair. If I go back to a little bit of history on this, for the last 15 to 20 years, there have been what is called the do not resuscitate form. It was a red form, which was traditionally used for many, many years ago. About 7, 8 years ago, I launched a frailty passport, which was adopted in a lot of areas within Staffordshire and Stoke-on-Trent, and which actually addressed exactly the same things, that what are the wishes of the patients. And this was instituted much before the patient actually um, would be in the last stages of life, so to speak. This has now been converted into a respect document on a national level, and a lot of, well, most of the admissions in the acute sectors will have a respect document, which is available now on the hospital computer systems, but also a lot of respect documents are also being filled in the community by GP practices and other healthcare professionals. And this respect document was adopted in Staffordshire and Stoke-on-Trent just before the pandemic on a wider scale.
Thank you, Amit. I think John wants to come in. The great thing about the power of attorney approach is this precedes one becoming a patient. And the earlier we start these discussions for us all, the better. John.
Yeah, so I wanted to build on that. So I think even before you get to that sort of power attorney stage, we have to change the whole dialogue around palliative care. So in some of the more advanced integrated care systems in the world, palliative doesn't mean just end of life. It means, when you're in a situation where you've got, severe frailty, and therefore that that this is managed deterioration now and decline, the importance of anticipatory care planning and really talking about wishes and what that journey is going to look and feel like, and what you do want and what you don't want, is incredibly important. And so we've deliberately built anticipatory care planning, early palliative care and conversations into that severe frailty cohort, so that we take that very open approach right through to those conversations about dying.
Thank you. Julia.
Thank you very much, Chairman. I totally agree with your comments about power of attorney. You need to be discussing those with your family or whoever you feel particularly close to well before you start getting ill. It needs to be a culture. We're all going to die. But we've almost got to the point in certainly, I think, the Western world where we're almost shocked, but it's inevitable. And when you've got, as you say, all your marbles, that's when you need to put things in place so that when things go wrong, there isn't a crisis because mum's had to go into a care home and there's no power of attorney and nobody can get hold of the money that they may or may not have. It's all been discussed in a level-headed way, a sensible adult way. And we've got to change the culture because, and I mean, you've heard me say this before, and I don't like some of these phrases, we have to get ahead of the demand curve. We've got to stem the flow of demand earlier and earlier. Otherwise, all we're doing is forever firefighting. And the one thing within this document, and I generally support what it's trying to achieve, a lot of good stuff in there, but it isn't explicit. It doesn't actually say what this is aimed at doing is not only providing a way of having a more active, independent life, but let's admit, we're wanting to reduce the demand on health and social care. Because if we don't, with the demographics, there's not going to be enough younger people around to look after us. And can I declare an interest being one of those old, decrepit, frail people who are over 70? The other thing is as well, it goes on about people over 65 and talks about diet and exercise and leisure and all this, that and the other. Everybody, whatever your age, needs to wake up in the morning with a purpose. And that purpose shouldn't just be about how I maintain myself. I do what I do because I get up in the morning, and apart from the fact I curse, I've got 300 emails in my inbox. I have a purpose to go out, learn new things, influence, and do things for other people. And that drives me and gives me a huge amount of energy. The bones may creak and the brain may creak from time to time, but it's that purpose. And there's nothing in this document that says we need to give people a purpose. It refers to, I think, about the number of over 50s that have dropped out of the workforce through the pandemic. And I mean, this is a national phenomenon. We ought to be encouraging those people to get back into work. We ought to be encouraging the over 60s, the over 65s, even the over 70s, to get back into work. Certainly not full time, but actually there's a ready-made workforce there with a huge amount of life experience. You know, we're desperately short of people to work in care homes and home care. You know, working 2 days a week, perhaps, would give them a purpose, fulfill a shortage in the workforce, and actually keep them active, keep them mentally active, stop them from getting lonely. There's nothing better than going to work and interacting with your work colleagues. So I think there's almost, when I read it, I thought, actually it's a bit depressing, because it's just accepting the fact we're all going to end up this way. And I think we need to be a bit more ambitious and realise, actually, people need a purpose in life, a reason to get up in the morning. I smiled about the access to health checks in view of the previous report we've had from Claire about people's complaints about access to primary care and GP. I wouldn't even know how to access the health checks. Come on, guys, we need to address that one. But I think the other thing, and it's building on what you've said, Chairman, we need to educate people, whether it's family, whether it's people in care homes, how to deal with death, how to support your mum, your dad, your aunt in their own home, and not to be frightened by the dying process. In the right environment, with people given the right skills, and they're soft skills. Actually, it needn't be the frightening, we've got to push this individual into A&E. I've seen elderly people come into A&E on trolleys, bewildered, frightened and dying, and you think, actually, if your relatives were given that little bit of knowledge to help them to manage this, that person would have had a far better death. So I think there's a lot of educating, because my generation were perhaps the ones that started to lose those skills. My mother and my mother's mother, you died at home. And that was expected. You know, it doesn't happen now. We've lost those skills. And I think there's an educational package, because otherwise we will be forever rushing dying people to die on a hospital trolley in an A&E department, and none of us really want that. So I think there are things we can do. It is the education. It's education about planning for your death in good time when you're fit and able to do so. But I do think we've missed a trick. We have to give people a purpose.
Thank you. No, I agree entirely. Gary.
Thank you, Chair. 3 points, if I may. I think really good to see this report today, really timely with the health and wellbeing strategy, and I think it fits in and slots in really well as a kind of delivery arm of that aspect of the strategy. Fully agree with all of the recommendations that were on the previous slide. Second point, to sort of address a couple of the previous points, we've got some really good work being done in Staffordshire by our hospices. to try and shift that dial earlier from end of life being right at the end to being conversations that happen much earlier. They're doing that work, particularly led by St Giles under the Compassionate Communities banner. So if I'll perhaps be in touch with Tilly about that to make sure we can bring them into this work and into the delivery of it, because I think they've done some great stuff already that we can build on. The third point really touches on what Julia said. What I kept thinking of through the presentation intermittently, where we were going right back to that point about Julia's point really about the culture, changing the culture. Many of you may have seen a Channel 4 programme where they took where they brought together a care home with a children's nursery. I don't know how many people saw that a year or two ago. And for me, that was coming right to the point that Julia made. Now, in that instance, it wasn't work, but it was bringing generations together. And I think there's something about the culture in this country that we divide everybody up into their demographics and we put them in a place separate from the other people. So we put all the old people away from all the young people to keep them safe and separate and secure and so they don't bother anyone. But in doing so, we take away their purpose, we make them lonely. And actually, not only that, we also do a disservice to the younger people who don't have that connection and relationship with older people. So I think there's definitely something culturally there. Now, that's much harder to write some very simple actions. A lot of the very clear and tangible actions in the plan there are the kind of sticking plaster actions rather than the fundamental underlying cultural actions. So I think for me, we will be succeeding in this if we can draw out some clear actions that address more of that underlying cultural point and the purpose of fulfilment point that Julia made. Thank you.
I recall seeing that programme, and I thought it was a real shot in the arm. There was a philosophy lecturer in Aberdeen who was quite exercised about the fact that people can now reach adulthood without never having held a baby in their arms or seeing somebody die. And in terms of the history of mankind, that's a very eccentric and different place to be compared to where we've been in the past. And I think that just helps put things in context a bit. Mark.
Okay, thank you. I mean, some of the points I wanted to make, Julie and Gary have touched on them. But if we go back towards the start, it says what will be different, the bigger picture. It talks about the aim being to improve healthy life expectancy and reduce health inequalities for older people. But doesn't that start much earlier than when people are already, as is described in here, older people? The activity below it talks about to develop new models of care and activity and capacity. And I just wonder whether there is a lack of ideas and thoughts in it about how we ensure that lifestyle for people, before they reach that is much better. And I'll give an example of both my parents who were born before the Second World War and went to school during the Second World War. My mum's still with us, but my dad sadly passed away. And both of them really I would describe as having quite healthy lifestyles, and not because they went out and did any running every day or anything like that. And my dad had never been to a gym in his life and never would be, could just about swim, but because he was always active and did an awful lot of walking, and my mum did. I think they were both probably well into their early 80s before they had any substantial health care interjection whatsoever. I mean, unfortunately, both then ended up with dementia. But physically, my mum's almost 90, and although she's got dementia, physically walking around, she's as, probably almost as able-bodied as somebody, generally 20, 30 years younger than her. So my view is that, that activity and lifestyle is probably the key and most important thing to, earlier on, to prevent the need, to enhance what we do when people are, only just in their old age as described in here.
I must confess, I'd wrote down 7 questions here, and I'm having to tick them all off because everybody's preempting me. You're absolutely right about that, Mark. The strategy is highly dependent on what comes before it in terms of looking at a lifespan. And the ICS and the public health here at the county, we need to do all we can in order to encourage people to develop the sort of life that Mark's just described, because we can't do it by the time people reach 65. You know, we're set in our ways at 65. Tim.
Thank you. I first of all like to start off by welcoming the strategy. Secondly, I'd like to agree with much of what has been said. I think there's a grave danger in our culture in this country about treating older people as if they're passive recipients of services and don't have a role to play. My father worked till he was 76 and would have happily carried on working for longer. My grandfather studied and wrote letters to everybody about his opinions well into his 90s, and thoroughly enjoyed doing it. I wanted to just pick up on the first discussion point we were asked to talk about, and the section in the strategy around primary prevention. There's some very practical things that we can do, I think, if we pick up what is hinted at in the strategy, but I think could be developed around an asset-based approach, and particularly around growing community assets. The authority I worked for before I came to Stafford had a very interesting pilot project where they went out and actively encouraged neighbours and families and corner shops and other people in the community to take an active role with their older neighbours to go and help them. So if they felt there was somebody who maybe in their social services parlance in danger of becoming a vulnerable older person, they would go and chat with them about who might help them. Now, some of that might have been initially premised about helping out with a bit of the shopping or having somebody to go to if there was an issue. But what it was really about in many ways was about company and preventing loneliness and connecting people. And as Julia put it very well earlier, around having a purpose. And I think we ought to consider actively as public bodies, but also as citizens, about how we can encourage that approach. I think we seem to have a bit of a fear these days about not interfering with others and not getting involved until we're asked, whereas actually we need to think of ourselves as active citizens engaged with the health and well-being of all of our neighbours and our communities, and feel empowered to go and offer help where we think it may be of benefit. And I think that would be a tremendous culture change. We felt able to do that during the pandemic in many ways, to help people check they'd got food, check they were able to get their prescriptions and so forth. We mustn't lose that good neighbourliness, because I think it can make a tremendous contribution to primary prevention. Thank you, Chair.
I would agree entirely with that, Tim, and Tilly would be able to wax lyrical about the supportive communities endeavour in Staffordshire County Council, supported by Gary and Support Staffordshire. And that's what we're all about, enhanced social prescribing and the like, because it's a virtuous circle as opposed to a vicious one, because people are helped, obviously, and those who do help improve their own morale and quality of life. So yeah, all for it. Can I just finally ask a question? Your bottom one is, how would the Health and Wellbeing Board wish to contribute to shape elements of the strategy that are more health service facing? What is the need to make a strategy for people to remain independent and to have a strength-based approach to life, to be more health service facing? I don't really understand the question.
Could I come in on it, Chair?
Do.
Yeah, so I think this is really probing at or pointing to the role that health and wellbeing boards have, and local authorities and voluntary and community sector partners within the health and wellbeing board for shaping services at community level, and actually inviting health services to work in a different way, getting close to primary care networks, bringing in community pharmacies, and actually bringing the social and the psychological parts of this to the health service, and saying it's no good just focusing on the physical. We've got to do this in a much more holistic way. And I think by the Health and Wellbeing Board setting that tone and leadership, that this has to be a holistic model, it has to be integrated, then it helps us within the integrated care system driving down the NHS to change the way that services are provided and the way they are received and felt to be received.
So you would, for instance, you would see social prescribing as part of that?
Correct. That's a really good example.
Okay, thank you. Thank you. Has this discussion helped in your deliberations?
I think it's more than helped. I think we need to do a bit of reshaping. I think the point about purpose, individual purpose, and has made me reflect that we've underplayed the psychological element of this in terms of people's sense of wanting to self-manage because they've got a reason to do so. I think we're going to have to go away and do an element of reshaping. So I'm very grateful.
It's a pleasure.
Johnny, can I just come in a second? One of the things, I think it's been a really, really helpful discussion, and there were quite a few points in there that I was thinking, yes, lots of things pinging around in my head in terms of that prevention strategy. Just a couple of things for me was Gary mentioned the links, the program around sort of nursery kids being sort of linked in with an older people's home. We have actually got a really good sort of intergenerational program that's run by one of the housing organisations. So it's some of those things that we need to keep connecting and reminding ourselves of what else is out there. And I smiled when Mark raised the point about age and when do we start in terms of the that healthy aging. Matthew's probably smiling as well, because we actually had a bit of a debate within our own group as to actually where do we start here. Somebody wanted to say 65, others were saying 55, and actually other people were saying 40. I suspect in terms of the health and wellbeing strategy, your overarching strategy is actually this is life course. This is about preparing our life right the way through in terms of the aging well. And then the other comment for me is just thinking about, as John said, we do, in terms of the strategy, there's a bit of rethinking, but also in terms of those recommendations I shared towards the end, it's probably about how we can link this work back into what Claire talked about at the beginning around the health and wellbeing strategy. So if you're happy, Chair, for me to sort of maybe link directly with Claire about how we can sort of get some of that sort of that synergy across the two plans.
That'd be absolutely fine, and I agree entirely. Life is seamless. Carving it up is introducing an artifact somehow. Matthew, do you have any closing remarks? Don't feel obliged by any means, but if you do, by all means, let's have them.
Thank you, Chair. I was really inspired by the comments around the purpose, which also reminded me of my 107-year-old lady who was playing on a Kindle. And when I went into the room and asked, what brings you to the hospital, etc., etc., and we had in the late evening about 2.5 hours of chat about this. And her clear message to me was, to stay happy, you have to have a purpose. And it never slips out of my mind. So thank you, Julia, for that. And I think Tilly has already mentioned around the seamless, healthier aging, starting from younger ages, and it is part of the strategy, as in the pre-frailty strategy. So, and similarly, the end of life, the power of attorney, and the dying bits are part of the severe frailty end. So that was just to give a little bit of clarity. But thank you very much for all your help and support and insights, and we're very, very grateful. Thank you.
It's a pleasure. Thank you all. Thank you. Can I now just, and you're welcome to stay, I can't imagine why you would, but you're welcome to stay if you wish.
Thank you then.
Thank you.
Can I now move on to the air aware piece? That's item 4 on the agenda. Cass Stevenson. Cass. And sorry we're late. You've got to press the button or I won't hear a thing.
That one there? Okay, lovely, thank you. This is better than standing up at the front, isn't it? Thank you. Hi, I'm Cass Stevenson. I'm here to present an overview on the AeroAir project that is DEFRA funded, delivered by the Connectivity and Sustainable Transport team with a public health sponsor. So it's definitely cutting across all the team areas. If we can move the slide on, please. The project is split down into 5 different areas. These areas link back into our core work that we deliver in our team anyway, but it just means that we are additionally funded to more intense engagement in areas where there is an air quality problem, and the areas cover business, school, the future of EV, on overarching communications, and some additional air quality monitoring stations. Thank you. I should have been joined today by my colleague Mark, who is our Business Engagement Officer, but unfortunately has lost his voice today, so he's passed it over to me. Working with businesses over the last 2 years, over the last 4 years, has been incredibly difficult. Their priorities have not been on public health, on getting their employees to walk or cycle to work. They've had far more pressing things on their mind. So this is the doom and gloom slide first, I'm afraid. Our aims and objectives we're working towards, let's put it that way. We haven't got the data that we want that will give us the information about what to do in the future just yet, but it's not for the want of trying. Mark is pictured there with our very own electric vehicle, and 3 years ago, when we had the first phase of the project, we were delivering our events from a diesel great big vehicle. Our aim was to get a new electric vehicle, and we have managed to do that. And that's working alongside our Amy colleagues as well, who are looking to change their fleet over. Thank you. So the good news with business is that we have managed to make some inroads. We managed to do quite a little bit since Mark started with us last summer. We had that break in November where we had to move back to digital, put any face-to-face events on hold. But we are getting there with some of our sites. I say some of our sites. Up to November, our 3 best businesses that we were working with were all NHS locations in Business, Cannock, and in Burton, Cannock, and in Stafford. Alongside Leek, but they weren't doing quite as well. Now, obviously, we can't go in and do face-to-face events, so we are trying to give them as much digital information as we possibly can, in the hope to get them up and running and ready for a summer of activities. The point that we have there about mode shift is we're trying to give these companies a plan that they can work on for the next sort of 5 years that will help them with their fleet plans, electric vehicle rollout plans, and how to run those campaigns for their staff and encourage as much active travel as we possibly can. We haven't mentioned it on there, but we've got a little bit of a plan with our lovely drive-throughs. I'm hoping that you are as much of a fan of them as I am. Drive-throughs give us quite a bit of concern about all those idling vehicles, and we have managed to get a few of the local McDonald's on board to do a few trials of how much pollution there actually is at some of those sites on a day-to-day basis. Thank you. The electric vehicle strategy for the County Council is running alongside this. My colleagues Louise Clayton and again Mark are working on this. We produced a feasibility study back in 2018-19, which gave us the information of what we should do, when should we do it, how and where. Basically, it was quite a vague plan because who knows what we should do and when we should do it and where we should do it. COVID definitely put a little bit of a halt on some of the plans, but we're looking at a 2-pronged attack, one for the public and one for our internal county council, including our fleet. This is running alongside our district officers, so we can try to get some sort of a consistent approach across the council, because all of the districts have got their own strategies, they'll be putting in their own charging points, and if you're an electric vehicle owner, I don't know how many people are, it can be quite a struggle at the moment to actually, we're talking about people doing their bit and taking responsibility. It is actually quite difficult at the moment for an electric vehicle owner in the county, especially if you don't have on-street parking at your residence. Thank you. I mentioned schools at the beginning as one of our strands. I have 3 school travel advisors that work within my team. We work closely with around about 60 to 80 schools between those 3 advisors. The one advisor that is purely AeroAir funded is targeting his engagement with 15 schools. So it's still a drop in the ocean for the whole county. Again, I've probably started with the worst slide, but I want to be realistic. These photographs were taken when schools reopened in September of, I'm losing my years, 2020. And that was following on from a county-wide campaign to try to encourage active travel to school. The councillor mentioned about his parents walking quite a lot. I walk to school. I'm sure if we were to do a hands-up survey of people who are in this room and on the videos, I bet the majority of us would have walked. It isn't that case now. The majority are coming by car. And they're not only coming by car, they are coming by car in sort of the behaviour that we're seeing by drivers is quite scary. I've worked in this field for 15 years, and it's the worst I've seen it this year when I've been out to schools. And parents, carers, grandparents, those that drop off the children at school, the attitudes were not the kind, compassionate community attitudes we saw in COVID. But if we can put the next slide on, it isn't all doom and gloom. Where we're working with, we are seeing some improvements. We are still hovering at around about that 41% of children that walk to school. The national average is 48. That data, by the way, includes our secondary schools as well, but I can provide that by primary school, faith school, rural school, urban school. We can break it down. We expect quite a lot from the schools that we're working with. We ask them to provide us with data, to take part in education for their children, to share campaigns to parents. And when all that perfect story comes together, we can see some really, really good work. Staffordshire has got the first platinum school for the country for school travel plans, Mode Shift Stars. That's with Heath Hayes Primary School, which has been our school of the region for the last 2 years. And our region covers quite a large area, sort of Midlands right the way up to Lancashire and Cumbria. So we're really proud of that. The reason why that has done so well, I would love to say it's just our team, but it's the attitude of the school. They've taken it on board, and they do everything and more that we can possibly ask them. It's actually sort of embedded in the school curriculum. Thank you. Air quality data is captured by our district officers and by our team using a variety of statutory monitoring stations and our handheld stations, but we still have some gaps. So within this project for the next 12 months, we have got some funding, it's 50,000, to target areas in Leek, Burton and Cannock where we're missing some data. And we want to know not only the data of what's really happening on the ground, but if any of our campaigns are actually working as well. So hopefully in 12 months' time, I'll be able to give you some really good data. And that should be a live dashboard as well for that data that we're capturing. Thank you. If you haven't seen this message by the end of March, then we're doing something wrong in our team and with our communications. An idling vehicle in your car, if it's running for 1 minute, just sitting stationary, it produces 150 balloons worth of air pollution. A HGV is 3 times that amount. And if you imagine buses sitting at the bus stations running for a long time, that's an awful lot of pollution that we could actually do something about. And that's just about raising awareness to turn off the engine. We have got a campaign running in the next couple of weeks. We've targeted 100 locations. We launched it on Friday, and we've already had 72 requests for packs. Nice, simple packs. with everything you need from sort of a guard railing banner to, get it the right way around, lamppost signs, just to try and get a little bit more visibility. So hopefully some of the sites that you're working with and on your journeys as you're driving around, you'll be able to see some of these messages. And if you can turn off your engine yourself, would really appreciate it. Thank you. So that's us from the team. We ask not only that people do their bit when they're in the car, but we do an awful lot of promotion to try and get people out of their cars. This is just one of the many projects within our team. And you mentioned social prescribing earlier. We're currently working on a bid for the Department for Transport to continue our walking, cycling message across the council. So thank you very much.
Thank you. Any comments or questions? Julia.
Yes, thank you very much for that presentation. Very interesting, and I know a lot of hard work does go on, and it can be quite hard, particularly over the last 2 years. I just wonder, a lot of the assessment of airwear is by, you know, the outputs are activity. Do we actually go and check that in those areas the air pollution has reduced? I'm very keen on air pollution outside schools. Young children, as we know, are more vulnerable to those pollutants. And I think your photographs said it all. It's a problem throughout the country, let alone the county. And I know a number of us as elected members get hounded to put parking restrictions in, which then subsequently get ignored. And one of the things I'm just wondering, and I'd appreciate your views on this, is actually, in order to reduce the pollutants outside school, whether we ought to have a far more rigorous parking enforcement, because it's very sparse with the best will in the world. It costs a lot of money to put parking restrictions in, and if they don't do any good, well, we're wasting taxpayers' money. You know, I think schools are a good area to make a start, and if people start getting parking tickets, they may decide it's cheaper to use a bit of shoe leather.
The parking restrictions and conversation is a daily activity in our team, definitely. We do work closely with the parking enforcement team, and we work closely with Staffordshire Police as well. We've actually rolled out a parking buddy programme and campaign as well that runs county-wide. You mentioned about the monitoring of the air pollution. Diffusion tube monitoring, it's actually done over a 12-month period, but to complement that, we can go to schools and we do go and actually live test what is going on at that particular time, and we can show the children, who can then pass the message back on to the parents, and that's the best way of doing it as well. But it's scarily high. The threshold, I'm not the technical person in the team, the threshold is 30, and we're regularly in the early 30s into the 40s sometimes outside the majority of schools, and it is parent behaviour. So if we can get those that must drive to turn off the engine, that's at least something. But they're parking on the pavements that then causes people to then feel that it's unsafe to walk on the pavements, is something that it's a constant churn of trying to get that message across.
So just carrying on that theme about idling outside schools, I noticed a few things come up on emails and different things about relaunch of the scheme. And I know in the past, I went to a school in Cannock because the cabinet member wasn't available, and I did a little bit on that for Midlands Today, I think it was. Is there thought about expanding it to other schools? Because I know one of my own parish councils approached me about whether they could work with schools to try and do something. And I think there's 5 schools within the parish. So I just wondered whether there is scope, whether there's any more funding to do it with other schools, and if so, is it through yourself I could make an approach?
Absolutely, yes, get in touch. We promote in all of the schools, asking schools to get in touch for if they want us to come in face-to-face and do activities with the children. And we've got digital packs as well, so that if the teacher wanted to do it and include it in part of their lessons, they can do that. And we have Clean Air Day coming up in June, so we'll be trying to get as many schools as possible. So your 5, absolutely send them our way. Thank you.
Am I live now? Sorry, I'm being very brave. I thought that was really interesting. So I work for Staffordshire Fire and Rescue Service, and we've just launched our environmental strategy. So I would like to talk to you outside of this and see how we can link in. But some quick wins are, we could share your link on our website. And I've also got a meeting with Mel Langdon from Staffordshire Safer Road Partnership tomorrow. And what you said about people parking on the pavements, and therefore people then feeling scared to walk on the pavements. I'm not sure if that's been spoken about as part of the Safer Road Partnership, and then the impact on the environment. So I'll discuss that with Mel tomorrow and link in with you. And also we've got big red fire engines, and we're looking at carbon neutrality. So again, it's something that we'll look at with the engine idling. I thought that was really useful, and I'll definitely take it back. Thank you.
Thank you. Just to say, the fire service have actually signed up for one of our packs, so that's brilliant. I know that you have the virtual Safe and Sound, which is something that we link into as well, but we don't link into it as much as what we should do. So yes, I'd really like to follow that up. Thank you.
I believe it, Carmel. Thank you. Thank you. I noticed there's somebody from the police here. Are you Sarah Wainwright? Are you? I just wonder if you have any comments to make about this.
Yes. I was going to take you up on the offer afterwards as well. Sorry, I was going to take you up on the offer as well afterwards, because we've just been looking at the reviewing the PCSO roles, obviously, police being more local, that local feel, and the PCSOs work well with the schools. With the parking buddies, and I think it's that more holistic view. It is the education. The PCSOs don't have the powers, and that's being reviewed as part of their role. But I think we've got to look at it as a more holistic problem, and this is quite interesting from a going in from a different angle, the way we work, and that influence the children have on their, I think that's far more powerful on their parents.
Some of us have discussed this issue with Ben Adams before, the Police, Fire and Crime Commissioner. Is it the case that giving PCSOs the powers in terms of inappropriate or illegal parking, that's a local decision, not a national one? Is that correct?
It's the decision of the Chief Constable.
Yeah.
Yes.
Yeah.
To give those powers.
Okay.
Yeah.
Okay. And is he considering that?
He's considering it, but actually what he's also looking at, because our concern is that would then end up being their primary role, which would take them away because
from the other stuff.
From the early intervention, the problem solving.
Sure.
So actually, how do we then make it part of the patrol strategy of the PCs?
Okay.
And then working with different partners to try and address it.
Okay, thank you. Thanks very much. Any other comments? Kath, thank you.
Thank you very much.
And we look forward to when you come with some data as regards whether your plans are working and just how well they are working. That will be very helpful.
Definitely. Thank you.
Thank you. Roseanne, you're online. Thank you. Along with Alan, I see. For the Better Care Fund. Over to you.
Yeah, that's right, thank you. So today, myself and Alan just wanted to give you an update as to progress with the Better Care Fund 21-22 plan since I last came to the board, which was actually in September, when the board delegated approval of the plan to the Health and Wellbeing Board chairs. So in line with this delegated authority, our Staffordshire plan was approved by the chairs and we submitted it to NHSE and I in December. We received notification in January this year that following the ongoing assurance process that the plan had been approved. In addition to the funding agreed and submitted in this plan, we've recently, as a system, we've identified an additional just over £19 million of non-recurrent funding, that can be used to improve and sustain health and care services in Staffordshire. And a summary of the expenditure against various schemes is in the paper that I've sent through in table 2. So hopefully you can see we've allocated expenditure across a range of really valuable services. Now that table is just a very high level table, and there's detailed plans behind it. But what the Better Care Fund planning guidance allows is that once plans have been submitted, they can actually be amended post-approval as long as certain criteria has been met. So as long as any changes are agreed by the council and the CCGs, and that they continue to meet Better Care Fund requirements. Changes need to be approved by Health and Wellbeing Board, or in our case, the delegated approval to the chairs, and they need to have been discussed with our Better Care Fund regional managers. Now, we've met all of these 3 conditions, and therefore we want to include this additional funding to this year's plan. It's been drafted and included within our Sector 75 to reflect the additional funding. And there are project leads that have been identified across the system that will lead on each proposed scheme. So the council and the CCGs between us, we're in the process of developing detailed plans for each scheme. At the moment, they're quite high level, but we wanted to put a bit more detail to them, including outcomes, what key performance indicators we'll have, the governance arrangements, so that we can make sure that we maximise the funding to the best effect for Staffordshire. So it's also important to note, that a programme of work is taking place to ensure that there's robust plans in place for 23-24 for each of the service for when this one-off funding ends. So as an example, Home First, that's been allocated around 6 million. This is an existing cost pressure this year that's been funded from a national COVID pot this year, and would have been a pressure in 22-23 had we not got this funding. So there's a big transformation programme underway, some of which was already planned pre-COVID but had to be put on hold because of the impact on COVID. So work started so that we can try and ensure that we've got the right capacity commissioned in 23-24, that it's used to the right effect, the right people are going through the system, and to try and address any cultural changes that we may need in the hospitals to make sure that the right people go through the service. So that's just one example, but for all of the schemes, there will be a dedicated programme of work to make sure that plans are in place for 23-24 when this funding ends. So that's the update on this year's plan. We haven't actually had any guidance for next year yet, but we're already starting to plan through the Joint Commissioning Board. And that was it for me on the update, Johnny. Is there any questions?
I think you've covered one of the questions in part. The first thing to say is that given the sum involved, which is 19.25 million, both the portfolio holder and myself as chair of this committee feel that it has to go to Cabinet. And the leader has agreed with that. So we need to take this to Cabinet, despite the governance arrangements that stand at the moment, whereby it's signed off by both chairs. I'm heartened at the fact that there's going to be proper KPIs attached to each of these, and we need to make sure that they're robust and that we know that the money is going to be well spent, because it's not just money going to stuff that we've done in the past with the Better Care Fund, and we know that works. This is a new set of allocations from what I can see. I'm glad you've raised this issue, because I'm particularly concerned that we become dependent on this one-off, such that in 23-24 we catch a cold, and we cannot allow ourselves to do that. And the financial arrangements have to be such that, or the way the money's used rather than financial, the way the money's used has to be such that we can't find ourselves with a cold come April 23 onwards. I think that's really quite important. Does anybody want anything to say? Julia?
I've certainly got no questions. I have to say that this money is very welcome. And certainly in terms of the funding for Home First, because I know that was making one or two people feel a little uncomfortable because that budget was overspent. I very much welcome the funding for the CRIS team for the South East and South West. There is one already operational in the north of the county. That system seems to be working well. So I really welcome that can now be rolled out county-wide. I was going to ask a question about, there is a line that's, I think it's about 750,000 for healthcare tasks, but I suspect there's more detailed work to do as to exactly what that means. I don't know whether...
I can answer that.
Oh, fine. That's great. That was the one particular question I was going to ask.
So the council at the moment, we have a Section 256 agreement with the CCG, so we commission health tasks on their behalf, so that if an individual requires home care and also some health tasks, it means that they won't have two care workers from two different agencies go in. They will have just a home care provider that we commission. And what we've found since commissioning these is that there's a lot of efficiencies that can be made, and there are also packages in place that are perhaps no longer required, or a practitioner or somebody from health has not had time to review their health needs. So what this is some additional funding to recognise that commissioned activity is overspent at the moment. And what we've got is a qualified nurse on secondment in the team and a team to review all of the health packages, so that actually in 23-24 we aim to be back within budget.
Thank you. Thank you. Alan, did you want to say anything?
Can I just add, Johnny, to what Roseanne, I think, and yourself were already saying, in that we are definitely in the process of ensuring that there's no recurrent cost pressure to the council as and when this funding ends. A large number of those schemes on there will be CCG responsibility. So in effect, they're pushing the problem down the road for a couple of years while they try and get themselves on track in terms of the funding for these schemes. So the ones that will impact us, as Roseanne has touched on, Home First, and Home Care is another one actually, and we discussed that this morning. We're absolutely make sure that there's no recurrent cost pressure, or that those issues are already factored into our thinking, our budget planning and our MTFS chair.
Section 117 will sit with us in the future, won't it?
The Section 117 line there, I know the detail behind that one. So this is around a wider piece of work we're doing to transform the way we work with our health partners to support people who have Section 117 mental health aftercare needs. So there's a whole area of work looking at the policy and guidance on how we work together and the pathways that we take those people through. Another part of the work is looking at how those people are funded. At the moment, we have a range of funding arrangements where either we pay 100% of those costs or health pay, or there's some other funding split in between that. What we've agreed as a way forward is that any new packages of care from the 1st of April will be 50-50 joint funded, and as and when new people come into the system, they will automatically be funded at a 50-50 split. What that means for us as a council is that we will benefit ultimately to the tune of £4 million per annum. But recognising the big impact that will have on the CCG, we are proposing a transitional period of 3 years for the financial arrangements to take place, and that 1.4 million in effect is covering off the cost pressure to the CCG in the first year of that transformation. So they're using that funding to bail themselves out in year one, or to offset that cost that they would incur from the financial transition of moving towards a 50-50 joint arrangement.
Gary.
Thank you, Chair. Take on board the points being made about not coming to be reliant upon this when it's non-recurrent. Nevertheless, I think it's in some of the pots that are under the CCG's responsibility, and it's in the detail, but my understanding is that there's a relatively small pot of grant funding that's going to come out to the voluntary sector, particularly in the south of the county. In that regard, that would be the first grant investment that's sort of NHS led, that's non-clinical, not in a pathway, not specified in a pathway. That'll be the first investment of that kind in probably about 10 years in the south of the county. So in that regard, it's a really welcome opportunity to try some stuff and to sort of prove the value of some of that work within the sector to our clinical colleagues in the NHS. So it's a welcome one-off opportunity in that regard.
It's particularly welcome in the light of the previous discussions we've been having as well, I think. Thank you. John, the forward plan. And thank you both. Thank you. And for your assurance.
Thank you.
Thanks. Bye.
John.
Sorry, excuse me. The forward plan will pick up next time. I think the key one is probably the younger age one. That was the infant mortality, healthy start. That's the word I was looking for. We'll pick that up next time because we've had a succession of kind of sessions where we've looked at what are the probable priorities within the strategy. So it's the younger end next time. We'll probably need to pick up the strategy again as well. Well, we will, but in terms of it's signed off, but how we action planning it and moving that forward too. So those are the two main ones. The pharmaceutical needs assessment is on for that agenda as well next time too. And if there's any others, let us know.
Any comments? Happy? The meeting's closed. Thank you very much.